Hi everyone, welcome again to the McLean Hospital Borderline Personality Disorder Family and Consumer Education webinar series. My name is Chris Palmer. I'm the Director for the Department of Postgraduate and Continuing Education here at McLean, also an Assistant Professor of Psychiatry at Harvard Medical School. My pleasure to welcome all of you today. Before we get started, a few logistical announcements. These webinars are intended to be interactive, but your microphones are muted and no one can see your name or information. But we do want you to ask questions. In the lower right-hand corner of your screen, you'll see a Q&A box, and you can type in your questions there. So if you've come to this webinar with a specific question in mind, you can actually go ahead and type it in now, and we will put all of the questions into queue and get through as many of them as we can. Secondly, I want to call your attention to the lower left-hand corner of your screen, where you'll see a lot of web-based resources. That first one is a link to our homepage where all of our webinars are archived. And so if this is one of the first webinars you've attended, you can certainly go there to view other webinars. And if you want to register for our next webinar, the second link will allow you to do that. The next three links provide our resources that are web-based around borderline personality disorder. So if you need referral information for a provider near you, or just want more information on borderline personality disorder, you can go there. And then finally, these webinars are supported through a philanthropic gift from a family that's been affected by borderline personality disorder. We would love to be able to continue them, but probably won't be able to do that without additional support. So if you're in a position to be able to support these webinars, it would be great, and there's a link in that box for you to be able to support these webinars. And now I want to introduce our two speakers for today. We're joined by Dr. Nina Lewis-Schroeder, who is a staff psychologist in our Dissociative Disorders and Trauma Research Program here at McLean Hospital, and also Dr. Amy Dierberger, who's a psychologist at the Hill Center for Women here at McLean Hospital. And today we're going to be discussing borderline personality disorder and complex post-traumatic stress disorder and how they can be similar and also how they can be different. So I will turn the webinar over to our two presenters now.
So thank you, everyone, for tuning in. We're really excited for an audience that we don't know. We don't know who you are and how many you are, but we're excited for the opportunity to spend some time talking to you about these two diagnoses. We will be focusing on their definitions, the symptoms associated with them, looking at overlap in those symptoms, but also differences, and thinking about how that impacts treatment considerations, treatment implications. We recognize that people tuning in today may have prior experience, prior familiarity with one or the other of these disorders or with neither. So at the risk of repeating information that people may already know, we're going to do some basic background information to make sure that everyone's starting with the same knowledge base today. So for starters, can we do the next slide? So for starters, here is our outline of where we're going to be heading today. We're going to start off reviewing the disorder, borderline personality disorder, the definition of it, and what the diagnostic criteria are for it. We will do the same for post-traumatic stress disorder, or PTSD. Then we're also going to talk a little bit about complex PTSD and what that adds to our understanding of just the regular PTSD diagnosis, and we're particularly interested and particularly going to be focusing on the commonalities and differences between BPD, borderline personality disorder, and complex PTSD. And then we will certainly be thinking about how this would affect treatment approaches, treatment considerations. Next slide. So borderline personality disorder. This describes a condition that is evidenced by a pattern of instability in relationships, in self-image. So that is how someone sees themselves, their self-concept, beliefs they have about themselves, and their affects or their emotions. And it also speaks to a pattern of impulsivity. As a personality disorder, these patterns are beginning by early adulthood, and here we have a nice long list of all of the symptoms that can go along with borderline personality disorder. You need 5 or more for the diagnosis. We're just going to break these down, take them one at a time. So for starters, frantic efforts to avoid real or imagined abandonment. This is really a hallmark feature in borderline personality disorder, this theme of fear of abandonment in relationships, really being a driving force for folks with this disorder, and can be a primary motivating concern in their relationships, leading us to a pattern of unstable and intense interpersonal relationships. Here's where we can often see a pattern of idealization and devaluation, going hot and cold in relationships, very black and white views about relationships, being in a relationship with someone, seeing them as all good, so positive, so pumped about this person, and then things can really change on a dime, a miscommunication, a misunderstanding, and all of a sudden sort of all the good things are forgotten, and the person is now being seen through a very negative light. And this pattern, this flip-flopping back and forth, can happen multiple times in the same relationship, and it certainly could be happening across different relationships. There's also the symptom category of identity disturbance. And by this, we are thinking about a sense of self-image. The idea behind this with borderline personality disorder is that it is unstable or shifting. And a lot of times what patients will describe is that they actually feel like chameleons in their interpersonal relationships, that depending on the group of people that they're around or the social situation that they're in, they're very good at going along with it, the hobbies, the interests, the likes, the dislikes of that group. But when they're not around that group anymore, when they're not around those people, finding that they're either shifting to match the new group of people that they're around, or if they're on their own, that they aren't even really sure, who am I, what do I like, maybe not even knowing their favorite food or their favorite author or their favorite movie. Next, thinking about impulsivity in at least 2 areas that would be damaging to the self. Lots of ways that this can play out. These could be things like overspending, shoplifting, reckless sexual choices, binge eating, reckless driving, abusing substances, recurrent suicidal behavior, threats of suicide, self-harming behaviors or threats of self-harming behaviors, affective instability, mood reactivity. So here's where we would be seeing sort of rapidly changing moods, often bottoming out in low dysphoric, low like depressed kind of mood state, or irritability or anxiety, maybe on the order of a few hours up to maybe a few days, and often changing or in response to social situations, things that are going on in the environment, or interpersonal interactions that are happening. Chronic feelings of emptiness, inappropriate or intense anger, difficulty controlling anger, so this could look like angry outbursts, getting into fights, getting into arguments, and transient stress-related paranoid ideation or severe dissociative symptoms. So stressful situations might cause someone to become a little suspicious or paranoid, or they might react in ways in the heat of the moment that afterwards they don't feel particularly connected to. Sometimes people will describe this as feeling like, I don't really know what happened. I was like in a blackout rage. I don't know what I did. Okay.
And we'll be talking about dissociation in the context of PTSD and complex PTSD as well. And for those who aren't as familiar, you will talk about it next. But again, the idea of being sort of separated from oneself, and I think the example Amy provided was really very common, often we see with people with BPD.
Yeah, absolutely. So now let's think about post-traumatic stress disorder, PTSD. And here are the diagnostic criteria for that. This is starting off with someone being exposed to either an actual or threatened situation with death, serious injury, or sexual violence. And you could be exposed to this in a variety of ways. You could directly experience it yourself. You could witness someone else be experiencing it. You could learn about something like this happening to an important person in your life, a loved one, a family member, a close friend. Or sometimes people have experiences in life, oftentimes occupational, where it's their job to be exposed to things like this. A first responder, someone in the military, someone who is like responding in like a disaster relief sort of way. So that's your criterion A. You would need to have experienced a traumatic event in one of those ways. And then there are a variety of symptoms that people can end up experiencing, and we're going to go through those symptom categories. First, we have re-experiencing or intrusion symptoms. These are ways that elements of the traumatic event come back to a person in everyday life. This could end up looking like having just intrusive thoughts or memories about the trauma replaying and unwanted and when they're replaying. Bad dreams or nightmares about the trauma happening when someone tries to sleep. People can have flashbacks. This is when they're going about their business in everyday life. Something happens, whether there's a trigger that they can pinpoint or not, something happens, and they feel like they're right back in it, back in that trauma time, back experiencing that event, often experiencing the same sorts of thoughts and emotions and body sensations that they were experiencing when the event was happening. And it can be tough to maintain connection with the present moment. It can be unclear, am I just remembering this unsafe thing from the past in a very full-bodied way right now, or am I actually unsafe right now? Am I actually in danger right now? Is this traumatic thing happening to me right now? So those are some examples of of re-experiencing symptoms. Moving on now to avoidance symptoms, there are lots of ways that we can avoid things that would remind us of past traumatic events. Some of these are internal reminders. We can avoid thinking about things that would remind us of past traumatic events. We can avoid feeling emotions. People sometimes describe themselves as feeling very numb with respect to events, traumatic events that they've experienced. People can avoid and push away memories that they would have about traumatic events. And body sensations that would remind them of the traumatic event may also be something that someone avoids. I'm going to talk more about that in a second. I also want to point out that there are external reminders of traumatic events that people can avoid. So this could be places, activities, events, objects, people. And sometimes internal and external reminders can overlap. Maybe you're someone who used to love exercising, but now you notice that when you exercise, your heart rate gets up, and that reminds you of what it felt like when you were in a traumatic event. So now you may not really feel like exercising anymore. You may start avoiding an activity that previously had been a nice thing for you. People may avoid touch. They may not like to be hugged anymore or be touched at all, even if that was not previously part of their personality, because that could be reminiscent of the traumatic event. Negative alterations in cognitions and mood. So this can play out in a lot of different ways. People can struggle to remember important parts of the traumatic event. They may carry negative beliefs about either themselves or other people or the world at large. They may find that they carry blame either for themselves or others or the world at large in terms of how they're making sense of the traumatic event. People may also find that they are just sort of in a persistent negative emotional state of some sort. So this could be through the lens of a particular emotion like fear, anger, shame, guilt. Those are all things that would commonly go along with PTSD. People may find that they are just not as interested in doing things that they used to enjoy, hobbies, pleasant activities, connecting with others. People can end up feeling disconnected from or like alienated from other people. And people may find that they struggle to experience positive emotions in the aftermath of a traumatic event. We also have hyperarousal symptoms, changes in people's reactivities. And what this could look like is having irritability, angry outbursts, engaging in reckless or self-destructive behavior, hypervigilance. This is when someone is sort of perpetually on edge, kind of always on high alert, looking for signs of danger, really monitoring their environment and whether they're safe in it. People may find that they are easily startled, sort of jump and react to stimuli in the environment around them, whether it's signaling danger or not. People may also have trouble with concentration and trouble with their sleep. All of these would need to be lasting for a month or longer and be causing people to have distress in life or impairment in their functioning. And then, as Nina was speaking to just a moment ago, there's also a dissociative subtype of PTSD, which could involve symptoms like depersonalization and derealization. What this gets at is a sense of feeling like you're disconnected from yourself, the world around you. People might describe this as feeling like they are watching themselves from like a half step away, almost watching themselves go through the actions, go through the motions of doing something. They may feel like they're in a dream, like things aren't real, like the world around them isn't real, or the world is distorted in some way.
And then we'll be talking a bit about what complex PTSD is and how it differs from PTSD and also BPD. So Judith Herman, who wrote Trauma and Recovery and psychiatrist responsible for the development of the Victims of Violence program at Cambridge Health Alliance, she coined the term of complex PTSD approximately 25 years ago. And complex PTSD differs from just straightforward PTSD in that it's defined as a syndrome that involves pathological dissociation, so what Amy was just discussing about depersonalization, derealization, emotion dysregulation, somatization, and extremely negative core affect, and having those symptoms in addition to the symptoms of PTSD that we just discussed. While complex PTSD has not been formally accepted into the DSM-5, the Diagnostic Statistical Manual, which is currently in the 5th edition, the World Health Organization has proposed its inclusion in the ICD-11. So we'll be seeing, hopefully, more incorporation of this diagnosis in a more formal way. But the other sort of key marker of complex PTSD that differentiates it from normal PTSD is that it occurs in the context of developmentally adverse interpersonal trauma, especially that occurs during times of developmental sensitivity. So we think about childhood trauma and trauma in adolescence. Could also be that somebody is maybe in early adulthood exposed to really chronic traumatic events, in which case this type of presentation would not be unusual to see. When we think about the long-term trauma that people, again, the chronic trauma that people may experience that leads to the development of complex PTSD, we also think about the fact that these traumatic events are what we would call often high betrayal trauma. And what we mean by that is that these events may have been perpetrated by individuals who should have been in either perhaps a caretaking role or in a position of authority, a position that should be trustworthy. So we think about, again, caregivers, family members, members of the clergy, foster care, these sort of systems where we think about children in particular being protected, and when that is not, that protection is not offered and in fact abuse occurs, we often see this type of presentation. So we think about complex PTSD, again, being a combination of the PTSD symptoms that we just discussed, the sort of intrusions, avoidance, hyperarousal, negative mood and cognitions, coupled with this chronic repeated trauma, and then resulting in tremendous difficulty with emotion regulation, negative self-concept. So again, this idea of who am I, my identity, as well as relational difficulties. And again, these particular struggles we see with complex PTSD often become sort of persistent across time and pervasive across different situations. So we may see that somebody has tremendous difficulty with trust in relationships, which would be entirely understandable if somebody had experienced ongoing chronic trauma as a child, and then that translating over not only into friendships or romantic relationships, but also into the workplace. So again, it's we talk about this as a distinct diagnosis or a separate diagnosis from PTSD because there is a different sort of origin for this type of trauma often, or this type of presentation. However, if we go to the next slide, we see that there is a common misdiagnosis of BPD, borderline personality disorder, and complex PTSD due to the difficulties, again, in emotion regulation, self-image, and these relational problems that are consistent across both diagnoses. The principal difference with complex PTSD is that the sequelae for this symptom presentation are exposure to traumatic stress, and that's not inherent in the diagnosis of borderline personality disorder, although there are high rates of comorbidity between PTSD and BPD. So what we do see, though, that the core features of dysphoria and borderline personality disorder, as Amy had mentioned, sort of betrayal, feeling victimized, the fragmented sense of self, the desire to self-harm, perceived ability to control affects or inability to control affects, that there is some overlap between the two, but they do present somewhat differently. So we'll be talking about that now, and starting with emotion regulation. So with emotion regulation, difficulties with emotion regulation are experienced by both individuals with borderline personality disorder and complex PTSD. And so this is one area where we do see a fair amount of overlap. As Amy had also said, affect dysregulation is a hallmark of the diagnosis of BPD, and we do see that people have extreme sensitivity often to, say, social situations or contexts, which can lead to a high degree of affect or mood dysregulation. So we might see somebody having either rapid or severe changes in mood as a result of perhaps a social interaction or some type of relationship that maybe goes awry. We also see with BPD that people experience frequent impulsive behavior. So again, this is suicide attempts or gestures, perhaps self-harming behavior. These are also witnessed in individuals with complex PTSD, and how it sort of differs, or how it's been suggested that it differs, is that this sort of ineffective coping choices that an individual may have could, with complex PTSD, could lead to sort of more impulsive or reckless behavior similar to BPD. What has been suggested is that they may be less frequent, so the impulsivity may not be as frequently engaged upon. However, there may be more high-risk behavior that occurs with that decreased frequency. In addition to, with emotion regulation, we might see reactive anger with individuals with complex PTSD. And so that might be either explosive anger that's sort of exhibited to other people, sort of an outward gesture of anger, and it could be also inhibited anger where maybe the individual internalizes their anger and takes it out on themselves instead. We also do see suicidal thoughts arise for people in the context of emotion regulation difficulties when it comes to complex PTSD. In the next slide, we'll be talking about self-image in the context of BPD and complex PTSD. So with BPD, again, as Amy described, individuals can feel an unstable sense of self or sort of emptiness about their own identity, not really sure, who am I? Am I finding that I need to be the chameleon, fit in with different groups depending on who I'm spending time with, sort of looking for something to connect with that might help define who the individual is, and not maybe necessarily feeling like you have a true self. And that also might contribute to a shifting self-image. So with one group of friends, I might feel like I'm one way, with another group of friends, I'm another way. What is really markedly different with self-image and complex PTSD is that individuals with complex PTSD often feel a tremendous and chronic sense of guilt, responsibility, intense shame. So feelings as though I'm responsible for the trauma that occurred to me. If I had not been bad, if I had not been, deserving of being punished, then these traumatic experiences, I would not have been punished or abused in the way that I was. There's also a tremendous sense of stigma that these individuals often carry, and it's a sense of being so different from other human beings, of being broken or damaged. We often hear people describe themselves that way. And it's this negative self-image that goes beyond just maybe saying, oh, I'm not good at this, or I'm bad at that, or, I don't like the way I look. It's almost so pervasive, and it's sort of built into their sort of core beliefs about themselves that it can lead to a sense of hopelessness that anything could ever be any different. And I think it also contributes greatly to relational difficulties, because it does lead to people feeling as though, because I'm so broken or I'm so different, how could anybody want anything to do with me? Or if I were liked by someone, then that must mean there's something wrong with the other person. So that kind of leads...
Or they just don't know me well enough.
Right.
If they really got to know me, if they knew the true me, they actually would like me.
It's a great example, yeah. Yeah, so if you're sort of a clinician working with an individual like that and trying to provide positive feedback, it can be really challenging because it sort of bounces right back, and it's hard for somebody who has these beliefs to let it sink in that somebody might actually have true positive feedback. So as we think about interpersonal problems, as Amy mentioned, the two BPD diagnostic criteria that are specifically related to attachment and security they're quite distinct between BPD and complex PTSD. So with BPD, we see this terror of abandonment, this fear that someone will leave me, I'll be rejected. And then this other quality of this alternating idealization and devaluing. So again, it's sort of putting someone on a pedestal and then subsequently potentially feeling as though they're the worst person ever. This is very different from the patterns that we see in individuals with complex PTSD. In those individuals, again, sort of keeping in mind the pervasive negative sense of self as well as perhaps the emotion regulation difficulties, you see that there can be a chronic avoidance of relationships. So very intense difficulty feeling close to other people, feeling as though trust is, it could be virtually impossible. Intimacy of any kind can feel like an insurmountable burden. This is not something that I could possibly ever do. And you may actually find that people with complex PTSD may engage in relationships and actually be able to develop them, but it's sort of the maintenance of those relationships and then not feeling like the minute somebody does something that might make them seem untrustworthy that they withdraw completely. And other patterns that we might see in relationships for those with complex PTSD could be related to perpetrators and feeling as though their perpetrators are sort of all-powerful and, even many years later in their life may still have the ability to harm them in some way. So all of these factors contributing to a sense of alienation from others, feeling like I'm so different from everybody else that there's no way that I could possibly have maybe healthy relationships or feeling undeserving of having those healthy relationships. So those are sort of the very key differences between BPD and complex PTSD that may on the surface sound very similar, but in fact have pretty significant treatment implications.
Yeah, and I think that's where we're going to shift gears to now. When we think about these more surface level commonalities between BPD and complex PTSD, but then as we actually sort of dip into it a little bit more, notice actually how these seemingly similar symptoms are playing out quite differently in people's lives, that is going to have treatment implications. So let's talk about that for a bit. Starting off with a review of treatment approaches for borderline personality disorder, there are many. There are a lot of evidence-based modalities. There's dialectical behavior therapy, or DBT, mentalization-based treatment, MBT, general psychiatric management, GPM, those are just some. Nina and I are going to mostly talk about DBT because it's what we do the most of and have the most experience with, but it is not the only way to go about doing this kind of work. DBT, developed by Marsha Linehan for borderline personality disorder, merges cognitive behavior therapy principles of change, with Eastern acceptance practices. So this is where we are balancing two things that seem like they don't go together. How do we balance in treatment the idea that someone is doing the best that they can, given what they've had to work with, given their, all things considered, current circumstances, they're doing the best they can, validating that, and also holding the other side of that maybe they could do better. Maybe there's room for growth. Maybe there's room for improvement. Maybe there are ways that they could be more effective. And DBT really captures this balancing back and forth between those two aims of treatment. There are four main skills modules within DBT. So DBT is very skills-based treatment. It is teaching skills in different categories. The skills categories are mindfulness, emotion regulation, distress tolerance, and interpersonal effectiveness, which already just on the surface sounds really good about it when we reflect back on the types of symptoms we've just been talking about. And as I said, DBT was initially developed for treating BPD, but it actually is helpful for a variety of diagnostic conditions, including PTSD. So now let's shift to thinking about trauma treatment. And before we talk about specific like evidence-based treatments for trauma, What Nina and I want to emphasize for people is the idea of stages of trauma treatment, stages of treatment for PTSD. This is not necessarily intuitive for people. I think that sometimes people are not aware of this, but there is a lot of both research support and also just practical, theoretical, and like on the ground, like hands-on clinical support for the idea that depending on what someone's symptoms are like and what their current functioning is like, that is going to suggest the direction that their treatment should take at that point in time for PTSD. So the idea is that there are 3 stages of treatment. They are not rigid. It's not like you do stage 1 until you graduate from it. You never think about these things again because now you're in stage 2. It is much more fluid. You can really be sort of shifting back and forth amongst the stages depending on how you're doing, how you're coping, how you're functioning, and what's going on in your life at that point in time. So stage 1, trauma treatment, some of the hallmarks of this are thinking about safety, establishing safety if necessary, maintaining safety, having some sort of stabilization, a regular structure, keeping up with functioning, whatever that means for someone. People are in different stages in their lives. Some people functioning, that means work. It may mean school. It may mean caretaking for family members. It may mean volunteering. It may be any combination of those things. It means taking good care of yourself. And often this means using skills, developing, learning, remembering, implementing skills over time so that these sorts of things, these stage 1 concepts are happening in a person's life in a reliable way, in a safe way. And sometimes I say to people, even though I think this is a hard thing to aspire to in treatment, but in this stage in treatment I do aspire to it, boring. Boring is nice for a bit. If you can just get things nice and calm and stable and boring for a little bit, we can make things more exciting later on. And for some people, stage 1 is actually where they choose to focus their trauma treatment, and that is fine. You could hang out there just focusing on those concepts, and people do report a decrease in symptoms and improvement in functioning. However, sometimes people, after establishing that, do feel like there's more work to do. They have the interest and the willingness and the motivation to do more work, and if so, then they can be moving on to stage 2 in their treatment. What stage 2 does is really builds on stage 1 trauma treatment principles and adds in that element of trauma details, trauma processing, talking it through, getting into it, working through it. A lot of times people assume that this is what trauma treatment is and jump straight to it, so that's why we think this is a really important slide and why we want to belabor this a little bit. I would say, first of all, stage 2 is an individual decision to make. It should be something that someone wants to engage in, and I would only recommend doing it if you have stage 1 principles down pat so that you are maintaining your safety and your functioning in your life. Stage 2, some principles of stage 2 certainly would involve getting back into trauma details, trauma content. Perhaps that might mean some grief or mourning work for whatever losses might have been brought about by the trauma. Sometimes people start making some personal sense or some meaning of their traumatic experiences. And then that sort of builds to stage 3, which I think is sort of tough to define because I think it's a very personal journey that people go on in their treatment with their treaters, but it can involve reconnection with social relationships, reconnection with the world at large, because as Nina was speaking to a few slides ago, a lot of times in the earlier stages of trauma treatment, people are not engaging with others. They are kind of holding themselves back. They are withdrawing from social connection. So stage 3 might be looking for ways that people would reintegrate, reconnect with the world around them. If people have found ways, like in stage 2, to make some sense or meaning of their traumatic experiences, they may be putting that into practice in a very real way in stage 3. And this could look so many different ways. Sometimes people do artwork, they do writing, they may do volunteer work, advocacy work. Sometimes people literally go in career directions that involves giving back to others or offering help or assistance to others in a sensitive or vulnerable position. That is something that people can have a sensitivity to and appreciation for after experiencing their own trauma histories. And I think stage 3 can also be a way in which people find a way to kind of put trauma in its place in their life. None of us have a time machine, so it's always going to have been there. We can't undo the trauma, but it doesn't have to be the defining whole of someone's life. And sometimes in the earlier stages of PTSD treatment, it kind of is. It can be like this gray cloud that's really hanging over people's lives and their functioning. It's kind of always with them. In stage 3, sometimes I like to think of it as like a pie chart. And if you have a pie chart diagram, and if you can think of trauma, it's just a piece of the pie of your life. But if you're growing your life around it in all these other ways, it's not the defining whole. And actually, maybe we can make the slice of the pie actually fairly small. So a very small trauma slice and a much bigger life in whatever way has meaning for a person all around it. So that's something that I want to make sure that people are keeping in mind as they're thinking about PTSD treatment.
And just to sort of reiterate what Amy was saying, that DBT really is a really great stage 1 trauma treatment approach. So it's a great approach to treating BPD, complex PTSD, and PTSD. And I think that, as we think about the stage 2 treatment, as Amy said, it's a very individual decision to move into that stage. But it's also important to remember that I think that if you're working with providers who are trustworthy and if you have that kind of good rapport with them, that it is something that you may consider and think about what the role of avoidance might be if it's something that you are, really not interested in. And that's not to push and say everybody has to do stage 2 treatment, but just to consider that avoidance can show up in lots of different ways in treatment as well.
Yep. So when we're thinking about treatment, DBT a natural fit for stage 1 trauma treatment because DBT is filled with coping skills. It is filled with the implication of we are trying to establish and maintain safety, and that is often what folks in stage 1 trauma treatment are in need of. And then there are a variety of evidence-based treatment modalities for PTSD that overlap nicely with some of the stage 2 trauma treatment principles. We have cognitive processing therapy, prolonged exposure, DBT, PE, lots of ways that that evidence-based modalities can be combined with the stage model of trauma treatment.
And some of what we would consider gold standard treatment approaches for complex PTSD include elements of DBT, so STARE, which we don't specifically mention on here, which is skills training and effective and affect and interpersonal relationship. We often combine that with prolonged exposure or with CPT, as it does have a very strong skill base to it that very closely mirrors DBT. So we do think about that as being an approach that just sort of has that stage 1 component built into it, even in a stage 2 treatment modality.
And so now, thinking about treatment considerations as a whole, tapping back into our goal today to talk about borderline personality disorder and complex PTSD, when we reflect back on some of the different sorts of symptom presentations and the different sorts of challenges with functioning that folks may have with BPD versus complex PTSD, this is going to affect what we might want to focus on in treatment. So if we are thinking about aims of treatment, goals of treatment, things to work on in treatment for borderline personality disorder, obviously a goal needs to be safety. So working to establish and maintain safety, that usually means reducing suicidality, reducing self-harm, eliminating them ideally. Also, though, working on that idea of the self-concept and helping sort of pump someone up so that they are developing more of a sense of themselves across situations, across audiences, and so that they are not needing to depend on others to define themselves or to feel like they have sense or worth or have a sense of self, that they have one, not dependent on another one to give them that sense of self or a sense of worth or a sense of meaning, and to reduce the dependency on others so that if there is a snafu in a relationship, if there is an argument, if there is a breakup, if someone disappoints someone, it's not catastrophic. It's not the end of the world. So those are some of the things that treatment for borderline personality disorder are going to be focusing on. Now, if we think about complex PTSD, some of the goals in treatment are going to be working on social connection, helping people find safe ways to kind of nudge themselves out into the world, thinking about how to make healthy relationships, and reducing that avoidance. Working on challenging that negative self-image and working on ways to sort of build it up and become more positive. And certainly, as we were speaking about with respect to the stage model of trauma treatment, if it makes sense for a person, if it's appropriate, and if they're interested in it, and if they are able to maintain safety and functioning, if it makes sense for them to get into more trauma detail work, trauma processing work, then that would certainly be a piece of complex PTSD treatment. Now, let's just close out with some thoughts about treatment considerations. These are things that are really treatment considerations for any treatment of any diagnosis, any disorder, although I think given the unique challenges of borderline personality disorder and complex PTSD, these are sort of all the more important and well worth repeating. So the therapeutic relationship is so important, so core. So it's really important that someone is working with a clinician that they feel like they have a mutually trusting relationship with, that they have rapport with. And I think I'm going to jump to like the last point before the second one. And as interpersonal struggles come up, as they probably will, because all of us are human and people step on each other's toes and have misunderstandings all the time, those are things to be addressing in real time. It's an active part of the treatment relationship, something to be to sort of just roll with as they come up and finding ways to skillfully problem solve them. Pacing is so important. I think when we're doing treatment with either diagnosis, you're wanting to find someone's safe zone and then find that sweet spot of where can we be pushing? Where is there room for growth? How could you do better? How could you be more effective? Where could you challenge yourself? So always looking to find like the growing edge, but pacing it so that it's not overwhelming, so that someone's coping resources, that their affective resources, their emotional abilities are not overwhelmed, and also recognizing that where someone's sweet spot is today may be different from where it's going to be tomorrow or next week or where it was last month, because life happens. Life throws us curveballs. It doesn't just wait for us to do our treatment. So that's something to be keeping tabs on. Something that we talk a lot about in DBT is self-assessment. Self-assessment skills, developing ways that you are tuning in with yourself and that your treaters can be helping you to do this. How do you tune into yourself to have a sense of where am I at right now? What can I tolerate, and what can I tolerate? What's within the realm of something I can work on right now, and what is beyond that for me right now? And grounding skills can be so important in their own ways for each of these disorders. Thinking about the ways in which someone could get overwhelmed with strong emotions, with tough memories, with symptoms of any sort, things can sort of pull somebody out of the present moment and make it very hard to use skills. So grounding strategies, grounding skills are part of treatment for either BPD or complex PTSD. And we'd be looking for ways to help bring a person back to themselves, back to the present moment. There's probably millions of ways to do grounding, so that would be something that someone would work on with their individual treatment team. And I think a few other points that I want to make. After we finished up this slide, I was very focused on like treatment considerations and thinking about a patient and their treatment team. And then afterwards, and after I submitted my slides here, got to thinking about all of those things can be happening in treatment, and there are other considerations to think about. And I realized that we probably have an audience that has perhaps some family members, friends, social supports of people who are undergoing treatment. Treatment affects you guys too. There are themes of things that come up in treatment for borderline personality disorder, for complex PTSD, that cannot help but seep into people's interpersonal relationships. Things like boundaries, that is a huge theme in treatment for both of these diagnoses. In borderline personality disorder, it may be around someone figuring out, perhaps for the first time, what is important to me? What do I value? What are my beliefs? What are my morals? What are my expectations? What's important to me? Where do I want to draw a line? With complex PTSD, people may be sorting these things out for themselves, or they may be trying on for size the idea that I deserve to have boundaries. I deserve to have limits. My beliefs, my expectations, my morals, my values, these things matter, and people should not cross them. It is okay for me to draw a line in the sand. So people may be coming at the concept of boundaries from different directions, but how it would play out in their treatment and in their lives may be similar, in that they may be practicing this in their treatment and may also be practicing this with safe, important people in their lives. And probably no one's going to get this right the first time around. So that is to be expected, that this is a work in progress, a trial and error sort of thing. So I wanted to highlight the idea of boundaries getting worked on, both in treatment but also getting worked on in life for people. I also wanted to highlight the idea, I think you probably can't emphasize this too much, that most people are part of a system. We do not operate in a vacuum in life, and if a person is working on making progress or making change for themselves in their treatment, there is probably going to be a ripple effect for that. A system sort of adapts to all parties in the system, and if changes happen with one element of it, that it will probably echo through other aspects of the system, and this may feel uncomfortable, unfamiliar as the system recalibrates. And I think that this is something that people can be expecting, the patient themselves, but also loved ones, people in their families, people in work environments, wherever. So I think that's a healthy thing to expect, but it can be quite uncomfortable and quite difficult in the moment.
Yeah, and with the stage 2 approaches that we mentioned in particular, that comes up very frequently because sometimes, well, most of the time there's homework that is actually incorporated into the treatment that requires interactions with friends, family members, loved ones, and so you may be invited to play a role in some cases in the treatment as well.
And in stage 1 work, because DBT, there are plenty of skills that would be an opportunity for homework assignments where you might be practicing with someone else, so that could happen in treatment for both conditions. So I think, last slide, I think that's what we had prepared for you all today, but we would love to hear reactions from folks and try to field any questions that people may have.
Great. So thank you for a wonderful presentation. We've definitely got questions coming in. A couple of people have already asked the same question. Can someone have both borderline personality disorder and complex PTSD? And if they do, how do you think about deciphering the difference? And does it matter? Does it matter where the symptoms come from, whether it's BPD or complex PTSD, in someone who presumably has both diagnoses?
So individuals can have both BPD and complex PTSD. Individuals can have BPD and PTSD. I think inherently in the way the diagnostic criteria is currently set up, you can have PTSD and complex PTSD. So there can be a combination of these diagnoses. And in terms of thinking about does it matter where it comes from, the reasons that we think about differentiating these, first of all, are for people who don't have both conditions. But if you do have both conditions, I think that the starting point would be the same with BPD and with complex PTSD, and sort of starting with the sort of safety skills and stabilization. So one of the reasons that we do talk about DBT so frequently in the context of these conditions or syndromes is that it really is kind of a very nice starting point for people. They're really sort of generally very good life skills, and I think it can help people to start to connect with themselves, as Amy was saying, with their self-assessment process, sort of identifying, how do I get in touch or name my emotions? How do I think about my relationships with other people? These areas that are impacted by both conditions. So both can exist at the same time, and in terms of figuring out where we start, I think we figure that out by thinking about how is your life being most impacted, right? So we think about, in terms of you're in a personal relationship, you're functioning sort of socially, work-related issues, all of those areas, and sort of start with treatment goals that are connected to where do you think that your life is being most impacted by these symptoms.
Yeah, and I would really agree with all of that. You read my mind.
So another question that comes up, and I think it's a pervasive kind of stereotype in our field and also among a lot of patients, that borderline personality disorder is associated with kind of a bad diagnosis. The person is bad, the person is difficult, the person is manipulative. And a lot of healthcare professionals, including mental health care professionals, will actually go on record as saying, I want nothing to do with borderline personality disorder. Those patients are just too difficult, too challenging. And there's almost, again, there's a perception that they're being bad, quote unquote, on purpose. And contrasting that with post-traumatic stress disorder, it's hard for anybody to feel bad or feel that someone's bad for having been traumatized. And it's absolutely taboo to suggest that somebody is somehow responsible for their PTSD, and let alone complex PTSD, where there presumably has been chronic trauma over a period of time from a trusted person. And then there's this perception that if you have borderline personality disorder and you have an anger attack, which is a symptom of BPD, that you should be held responsible for your behavior, and maybe we get that you have intense emotions, but you've got to be held responsible for it. Whereas if somebody with complex PTSD has an anger attack, they may get more sympathy. because it's kind of like, oh, you've really been wounded, you've been hurt so much, and you somehow aren't responsible. How do we move forward as a field, and how do we move forward in terms of stigma and stigma reduction when these perceptions exist?
Very good question.
I think
it's a really important topic to discuss. Yeah.
I mean, I think partly, I think that there is a lot of, and then I think if people sort of learn about a diagnosis and go into Google and start seeing what some of the reactions that might be on the web, I think that can fuel all of this. This is not going to solve the problem, but I think one of the points of sort of how we organize our presentation and how we think about it is that there's a lot of treatment modalities for BPD. I think part of the stigma is that this is just how someone is, always going to be this way. If you're a treater and you don't have to treat them, more power to you. If you're living your life and you don't have to be in a relationship with someone with this, try to stay away. And I think that part of the fact that there are effective treatments for it sort of undermines that thinking a little bit. So that's one thought that I have. Another thought that I have is that while the origins of it may differ, people's distress is real. The effect on their functioning is real. And I think you can butt up against stigma, certainly towards BPD. I think you can butt up against stigma with PTSD or complex PTSD, although I think sometimes it's more of a self-help stigma of that patients might turn inward towards themselves. I don't know if a patient with complex PTSD would feel like they aren't stigmatized.
I mean, I think I agree with what Amy's saying, and I think that there is tremendous, I think that obviously we know that there's stigma related to the diagnosis of borderline personality disorder and for all the reasons that Amy and Chris mentioned. And there is also stigma related to PTSD and complex PTSD, certainly working in a first responder population, which is a lot of the work that I do clinically. There is a lot of shame associated with being impacted by traumatic events that is increased by potentially having complex PTSD due to childhood trauma as well. So that feeling of being so different and being so broken, I think even if you might say socially, oh, this person has PTSD, therefore we may need to excuse their behavior, that's not necessarily how the individual conceptualizes it. And I think at the end of the day, an angry outburst, whether it's due to difficulty with emotion regulation from BPD or complex PTSD or PTSD, just regular PTSD, individuals, when we think about that in treatment, it doesn't matter. We're looking at the behavior itself, right? So we're looking at how is that impacting your life? How is that getting in the way of you having the life that you want to live? And so addressing the treatment targets, we would look at the behavior as behavior, and I think as clinicians probably not say, well, you have PTSD, therefore it's okay that you threw something against a wall and broke it. We wouldn't look at it that way. We would say this is something that we need to work on because managing anger and managing your emotions is a really important part of maybe being the person you want to be in relation to, family members, friends, work. So, but it's a tough question, and I know that it does feel like, well, if there's trauma in the picture, it might excuse certain behaviors, or it's hard to feel as though you can blame somebody, but at the end of the day, behaviors are what we would be looking at, right?
Yeah, great. No, I think that's helpful. The next question is, can you address any modifications that you might consider when working with service members? You mentioned that you do some work with first responders, and so are there differences in thinking about how to work with service members, military veterans?
Differences in terms of treatment?
Differences in terms of either conceptualizing it or treatment.
So I think, and Amy works with first responders as well at the Hill Center. I think that the way I look at it is, we look at individuals and look at their clinical presentation and what they're bringing forward into treatment as what their treatment goals are. And so it may be that an individual has experienced really chronic, repeated traumatic events through maybe it's military service, for instance, and they've been on really sort of multiple deployments where they've experienced tremendous amounts of trauma, and that might be the trauma that they experience in that context may be exacerbating either earlier in life childhood trauma or other traumatic events that they've experienced in their life. So in terms of sort of how we would approach the trauma, depending on what stage of treatment we're in, we certainly, I think, would look at it in a similar way to providing treatment to anybody else. But what we would consider are that they're, knowing that, again, within the system, those systems that first responders, so military, police, fire, EMTs, the systems that you're working in are often highly stigmatizing towards the diagnosis of PTSD. There is, despite significantly higher rates of PTSD in those populations, I think a strong sense of, we just have to sort of suck it up and deal with it and be tough and keep your chin down and, get through it. And so being mindful that there may be increased difficulty in connecting in treatment, developing trust, feeling as though you might be willing to disclose or talk about trauma. We would be mindful of the difficulties that an individual might confront given the sort of larger system that you might be part of. Amy, do you have anything to add to that?
Yeah, I think we would be trying to meet any patient where they were at and figure out their unique set of circumstances. But I think sort of piggybacking on what you said, sometimes the patient who is maybe not part of one of those fields, they might be more likely, who knows, they might be more likely to have a more supportive work environment or family environment. Sometimes you'll get a patient who's a first responder or military, and their entire family or so many family members, sort of like part of being in the family. So that might, if the stigma is carried within the family, having that same sort of, say, military mindset or first responder mindset, there may not be the same sort of like social support that other patients might be able to tap into. So I think we would just, as we're getting to know a patient, figuring out sort of what are their goals and what do they have to work with, and what are they going back to after treatment, or like either when they complete their treatment. The program I work in is a 2-week program, so I know people for 2 weeks and then they go back to life. Or if you're seeing someone on an outpatient basis once or twice a week, ongoing indefinitely, what are they going back to after they leave your office that day? Sometimes I think there needs to be some adapting of expectations, and they may be able to conduct themselves or connect with things in a certain way in the treatment with the treater, and that may not be available to them elsewhere in their lives, at least at this point in time.
And so another difficult question for you, so just prepare yourself. but this has come up more than once. So this viewer says, I thought my daughter has borderline personality disorder. She's now told me that she has complex developmental trauma. She claims that she was sexually abused by her father and that I knew about it and did nothing about it. There were no signs, and now she blames me for her mental illness. She seemed to be a very happy child and actually excelled until she was 21, when she became severely depressed and suicidal. How should I think about this as a parent? And, this person says, is she just grasping for reasons for her mental illness? I would even add in that there's at least concern that some people with borderline personality disorder, but also with PTSD, can be much more impressionable and subject to suggestion. And certainly in the 1980s and 90s, there were some unscrupulous clinicians who believed that symptoms were from complex PTSD and childhood sexual trauma, and because the patients were impressionable, they were kind of led down a path, almost like a hypnotic state of believing that something had happened to them that probably didn't. And how do we think about like that really confusing picture? And what do we say to this mother who feels like she's on the hot spot?
Yeah.
She clearly didn't know if something was happening. She didn't know about it, but her daughter seemed convinced that she did.
Yeah, let's work our way through pieces of this. I mean, I guess the initial response I have, just in a sort of there's an actual live person with this question, and this is the sort of scenario going on in their life. I guess the advice or a suggestion I would have to this mother is, how can you meet your daughter where she's at right now? None of us can go back and redo anything, or, we only have access to what's in front of us right now. Where's her daughter at right now? What's her daughter working on? Is her daughter asking anything of her? Does she want anything of her now? I think this could be the sort of thing that if the mother is not already and was interested in this, could sort of seek out her own therapy just to kind of have a place to unload. And I can only imagine the sort of reactions that someone would have receiving information like this and feeling like it's really coming out of the blue, and they don't really have a framework to fit it into. And I think that's a work in progress to sort of see, the daughter may or may not want the mother's involvement in her own course of treatment. I don't know if you have any thoughts about that kind of piece.
No, I mean, I would agree with you that, I think this is something that we deal with on both sides. Individuals coming to treatment and saying, I experienced this abuse, I feel as though I wasn't protected, someone must have known. And then on the other side, having parents say, I really didn't know. If I had known, I would have done something. I mean, it's just such a difficult position for both sides to be in. And I think, as Amy said, it's sort of meeting, both people are where they are, so it's finding your, being supportive. And I think the struggle can be in sort of going back and forth, did this not happen? The fact is that your daughter may be, or in this case, the daughter may be dealing with a particular sort of symptoms. It sounds like some suicidal behavior. So it's going to be trying to help her to get to a place where she's feeling stable and getting the support for her, even if it doesn't come from within the family, until there's sort of more space or time to think about the implications of this sort of bigger picture for this particular family. But the false memory piece, though, of this, and sort of the idea that people are sort of suggestible and children are suggestible, there's obviously there's historically been a lot of controversy around this. I think from a sort of straightforward treatment perspective, when you sit with somebody who has complex PTSD or who has PTSD, there's really not much more I can say than there's something you can sort of feel with sitting with an individual who's had some of these experiences, and the tremendous shame and self-loathing and the truly pervasive sense of being in some way so different and so damaged by their experiences. I think it's sort of working with the person and working with what they're presenting, and for all intents and purposes, what they're sharing with you is their experience, and believing them and being a sounding board for them. Even, again, you're not going to necessarily jump right into a stage 2 treatment, but just being a place for people to talk about, where they are and the difficulties they're having in life. And that's why we think about trauma treatment from this kind of stage-based approach, because we really want to provide scaffolding for people to feel safe in a treatment, to not necessarily explore and dig up. It's not that we want to be unearthing memories, but to give them a place that's sort of safe to do work, to maybe get to a place to sort through some of this. I don't know. I don't even know if I'm answering the question. I feel...
Yeah, no, I think like you did. I think there aren't easy, quick answers for any of it. And it's a complex topic, but I wanted to bring it up because it is a complex topic, and these are the types of topics I think people are really hoping for us to address in these webinars, and to at least have a conversation. So thank you both so much. This was really helpful. We're actually a little past our time, so we've got to stop for today. I just want to let viewers know that on your screen you'll see that our next webinar is Thursday, December 21st, and there's a link that you can click on to register for that webinar if you'd like to participate.